our last speaker of the day, but certainly not the least, and is I'm actually looking really forward to hearing her speak, is Dr. Kathleen Van Dijk from UCLA. Hi, Kathy. Carrie, can you stop your slides and then sharing, and then we can get Kathleen up? There we go. And while she puts up her slides, I will introduce her formally. So Dr. Kathleen Van Dijk is an assistant clinical professor in the Department of Psychiatry and Behavioral Biosciences at UCLA. She got her PhD in psychology and neuropsychology from the City University of New York, and then did her externship at Columbia University Medical Center and a subsequent postdoctoral in geropsychology at the Johnson Cancer Center at UCLA. Her area of expertise is cognitive function in breast cancer survivors, which is a huge issue, and I'm looking forward to as a neuroscientist myself. And she's been a recipient of grants from the NIH and the American Cancer Society, and really looking forward to your talk. So the floor is all yours.
Thank you. Thank you very much. We're really excited to be here. And it's an honor to speak with such distinguished panelists. I really enjoyed the talk so far. So I am going to be giving an overview of what we know about cancer-related cognitive problems. And largely, this literature is in the area of non-metastatic disease, and a lot of what I'll be presenting is from breast cancer survivor studies. That being said, I think it's an area, metastatic disease is certainly an area that needs more focus and needs more attention and better understanding how the metastases and treatments can interact with the brain and change functioning. And I appreciate Dr. Steegs and Dr. Anders' comments in that regard. Okay, so I'll get to it. So I'd like to start out discussing cancer-related cognitive issues by thinking about the history. And this is what I find fascinating, is that this area has really been driven by patient report. And so what you're seeing here on the right is 5-year survival rates, which have been going up largely across most types of cancers. And you'll see this kind of dramatic increase in the number of articles that you see on PubMed and online about cancer-related cognitive impairment. And so a lot of this work began with the term chemo brain, and I'll talk a little bit about why that's a bit of a misnomer, why we're switching over to cancer-related cognitive impairment in a minute. But I think it's just important to recognize the issues have been exponentially getting attention. Oops, hang on. There we go. Okay, so, there are a wide range of reported rates for cancer-related cognitive problems, and just giving you kind of a smattering here from the literature. So within the past year from treatment, the sample that was surveyed for the Livestrong study, 45% reported that they had cognitive problems in the last year. In the sister study of breast cancer survivors, 60% had reported that they had some kind of cognitive issue after treatment. And what I find particularly disheartening about that study is that of that 60%, only 37% have actually talked to their provider about it. And so the authors had gone on to then suggest that maybe there was some discomfort, or they didn't feel like they wanted to bother, quote unquote, their doctor with these problems. So I think there's a real need to elevate the awareness about these issues and discussion. The field in general has landed on a number of about 20 to 25% of non-CNS cancer survivors who have some kind of cognitive difficulty or some kind of lasting cognitive problem after treatment. But it's still we still have a lot of work to do in terms of characterizing it and really getting down into what's going on. The reported cognitive problems and the cognitive issues that have been documented with neuropsychological and neurocognitive testing have been backed up by neuroimaging evidence. So I'm just giving you a bit of a survey here of some of the neuroimaging studies. So in panel A, all of these are looking at before and after cancer treatment or chemotherapy, excuse me. In panel A, you're seeing changes in gray matter volume, so a shrinkage of the gray matter in the brain. In panel B, you're looking at white matter tracts, the highways of the brain, and there has been some degradation of the integrity of the white matter tracts after chemotherapy. And in panel C, looking at functional activity, doing a working memory task, and changes in how much energy the brain needs in order to achieve that task. So we're seeing a signal, and we're hearing from patients that they're having problems, and we're seeing changes on testing. So the field as a whole is really working to wrap its arms around what's going on. Just to give kind of a sense of the types of issues that patients describe, and this is often what I hear clinically when I see patients, that there's this fine degree of memory or speed of thinking that changes, they struggle to remember things, they feel not as sharp, that their edge is gone, they feel mentally spent. A lot of times, patients will report that they are having problems coming up with the right word, or that they can't remember a name as they used to. So it's typically not a dramatic change in cognitive functioning, but that doesn't mean that it's not one that can be very distressing and disruptive. It's typically more mild and subtle, but it is certainly something that can be that can interfere with functioning and quality of life. So breast cancer survivors, who have these problems, talk about concerns about their job performance. They have reduced self-confidence. They feel overwhelmed. And what the literature has said is that it would have been nice if the patients had been informed that this was a possibility before treatment, so they could plan. And I think that that's a really important comment from a patient, because the surprise of having these difficulties after treatment is over can be incredibly distressing and confusing for patients. So initially, when researchers started looking into the question of what was going on in non-CNS cancers, the toxicity of chemotherapy was thought to be the main culprit. And it certainly is still one of the primary culprits. So there's some studies that have shown, changes in cognitive functioning 20 years after exposure to chemotherapy. But as the chemotherapy regimens have gotten less toxic, less neurotoxic, we started to see a bit of a reduction in the severity of those symptoms. That being said, the researchers are also looking at various other aspects of cancer treatment and how those can impact cognitive functioning as well. So there are studies that report changes in cognitive functioning after radiation. Some studies have reported changes in cognitive functioning even before treatment. And one of the things that I've been particularly interested in what I've been developing my research lab in, is understanding the effects of endocrine therapy on cognitive functioning. So I'm going to take a little bit of a detour and walk through that for a minute. So as I'm sure most of the audience knows, about 75% of breast cancer patients have hormone receptor positive tumors. So the estrogen is feeding the tumor. And these are then treated with aromatase inhibitors, which reduce the endogenous estrogen in the body, or tamoxifen, a selective estrogen receptor modulator, which blocks an estrogen receptor, but doesn't change the amount of estrogen in the body. So one of the studies that I worked on with my mentor, Dr. Patricia Gans, was looking at neuropsychological functioning in women based on whether or not they received endocrine therapy after their primary treatments, meaning chemotherapy, radiation, or surgery. It was a prospective naturalistic study, so there's a lot of error in those types of studies, but really we were just following these women from before they may have started endocrine therapy, 6 months after, then 12 months, and then there was a follow-up about 3 to 7 years later, depending on when they were enrolled in the study. So we really got a good sense, a good swath of time to look at neuropsychological functioning in these women. And what we found was nothing. So we found that there were basically no differences in neuropsychological functioning based on whether or not someone had been exposed to endocrine therapy treatment or not. And so I looked at this data every which way because I know that this is a complicated question, and prior literature has shown some changes. Some other researchers have found no changes. So I think there's still a question about what's going on. So thinking about the results of this study and knowing that there is significant report of cognitive changes for some women on endocrine therapy I am working on developing a study right now that's looking at different aspects of what hasn't been looked at before. So neuroimaging, maybe the measurement sensitivity isn't good enough. We're not quite sure what the mechanisms are. We know that these agents cross the blood-brain barrier. We know that there are estrogen receptors all over the brain in important areas. And no one yet has looked at the impact of the woman's menopausal status on as a predictor of whether or not they will ultimately have any cognitive problems as a result of these treatments. So bringing it back to the broad conceptualization of cancer-related cognitive decline, the field right now is really looking at this problem as a multifactorial issue, that there are a lot of different factors that can go into whether or not someone is experiencing cognitive changes. So of course, including cancer and cancer treatments, but also other comorbid conditions that the patient might be dealing with, like cerebrovascular disease. Stress and depression is a big part of it as well, in terms of, we know that stress can have a negative impact on cognition, both in terms of the hormonal effects, but also just the neurocognitive aspects of the internal thinking and internal depression that can happen. And I talk about that a little bit later. Sleep disturbance is a big factor as well, something that we're looking at more closely. Cognitive reserve, the idea that someone brings with them a certain amount of resilience against these issues. So it's an evolving tale of understanding what's going on, but this is a kind of an overview of why we think these issues might occur. So one of the ongoing models is the idea of accelerated aging, the idea that these cancer treatments are actually, through a variety of mechanisms, inducing a bit of an acceleration in brain aging, because we see similar types of aging-related patterns in the types of symptoms that someone develops. And so it's not proven, quote unquote, yet. It's still the ongoing model, but it's consistent with the idea that was discussed earlier in terms of neuroinflammation and oxidative stress and a variety of overlapping mechanisms in brain aging with what we see in preclinical and clinical models of cancer-related cognitive decline. So that this model is also kind of explaining why we're seeing these overlaps, what we're seeing in terms of overlaps. So the idea that there's a acceleration of the reduction in telomere length, which is the genetic cap that then allows a cell to reproduce, increased oxidative stress, DNA damage, which we found in our study as well, was associated with cognitive problems and cellular senescence, cellular death. And so there's similar overlaps in these two issues. So we're using aging as a model to try to understand what's happening for patients who are experiencing cognitive problems. Okay. So another area of research that I've been working in and I'm very interested in is trying to understand what we can do about it, both in terms of prevention and also treatment. The bottom line is that more research is needed. There's a handful of studies out there right now that have looked at this, and so there's ongoing development. But what I'm going to do is just walk through a couple of the known ideas or the more promising ideas that are out there in the literature right now, and then talk a little bit about some very basic strategies that I might review with a patient in terms of cognitive rehabilitation. So there are guidelines for asking and approaching patients and assessing for cognitive difficulties. These are the ASCO guidelines, referring patients when they have problems, and assessing for reversible contributing factors, which we'll talk about in a second. So there are guidelines, and I think that the stats that I showed you earlier are kind of getting at the idea that this isn't something that's as widely discussed and brought up as perhaps could be. So there's a lot more work to be done in that area. In terms of treating contributing factors, so things, we think about, well, what can we do something about in that kind of multifactorial model? We can't take away cancer and cancer treatment. That's done. That's history. So, but perhaps we can elevate and improve some of these other contributing factors, and that will lead to an overall improvement in cognitive functioning and well-being. So things like improving sleep. There's a study that found good efficacy for an app, a cognitive behavioral therapy for insomnia app in breast cancer survivors. So de-stressing can also be very, very overlap with sleep as well. So things like meditation, mindfulness, exercises, yoga, and increasing or sustaining physical exercise. So, it's not news that physical exercise is good for you. And there are a few studies that are going on right now, and a couple of small studies that have found some improvement in cognitive functioning after the introduction of more physical exercise. The other possibility for treatment is cognitive rehabilitation. And there are a handful of studies that have looked at cognitive rehabilitation in cancer survivorship, and they've all found pretty good results. So for those who may not be aware, cognitive rehabilitation involves a lot of different components: education, reframing what's going on, meaning trying to change perspective so that we can approach a problem in a different way. Distress management is a big part of it. So the distress that can come from experiencing a perceived cognitive problem, and compensatory strategies. So I used to be able to just go to the store and buy, a gallon of milk without needing a list, but now I need a list. At the end of the day, I still get milk, but I had to use this compensatory strategy. Okay, so I wanted to give you just a flavor of what some of these strategies look like, and what we do, what I do when I talk to patients. So really, focusing in on the individual patient's needs. What does their desk look like when they're working? Do they have dings all the time from emails? Really trying to help patients clean off their physical desk and their mental desk to help them focus and improve attention. And making sure that they have carved out time, that they're not to be disrupted, having a do not disturb sign, communicating with other people so that they're left alone and they're not distracted, organizing their time so that they have particular chunks of time to address certain tasks so that they don't feel like they have to do everything at once, because multitasking is often something that patients struggle with. Helping to use basic memory aids. So how do you maximize the use of your phone or the use of your calendar, or just a plain old paper and pencil, in order to get where you want to go, in order to function the way that you want to function? And lastly, one of the components that I've been working on researching and also incorporating into rehabilitation services is the idea that I've seen clinically much more often than not, the idea of this loss of self-confidence that accompanies experiencing cognitive changes. A professor giving a lecture and not being able to come up with a famous researcher's name off the top of the tip of their tongue. So it really can be a very unsettling issue for a lot of these patients. And so we'll work on positive self-talk, really generating just some internal monologue of that it's okay in order to move on. And so the research is looking at, some researchers have found that there's a trauma aspect to the development of cognitive difficulties. And so we'll work, this type of intervention helps to work on that as well. So there's a lot of different ways that we look at to help patients. And like I said, we're still we're still, in need of a lot more studies and a lot more data, but we're trying to come to an understanding of why these symptoms occur and then how we can help patients function and have optimal quality of life if they are experiencing these symptoms. Just some more references. And I'd like to thank my primary mentor, Dr. Gans, who's been wonderful, and my as well as the patients who volunteered their time for the research that I've worked on, and my funding institutions. Thank you all for your attention.
Thank you so much. I mean, I think this is great to have you on, on the panel as we're going to proceed to it. I think it's a lot of patients, have these cognitive issues, and I think this is going to be a emerging field, even more.